Hello, everyone, and welcome to our module on psychotic disorders. Let's start with schizophrenia, which is the classic psychiatric psychotic condition. Schizophrenia is a chronic psychiatric syndrome, and to keep it simple for yourself, you can basically think of schizophrenia as involving three things. First of all, patients with this disorder have recurrent episodes of psychosis. They also have cognitive dysfunction, and then finally, they have something called negative symptoms, which we'll talk about in a minute. In another video, I talk in detail about what psychosis is, but by way of review, psychosis is a loss of perception in reality, and it can occur in psychiatric disorders like schizophrenia, but it can also occur in medical disorders like delirium. And there are three key features of psychosis. The first is delusions, the second is disorganized thought, and the third is hallucinations. In the video on psychosis, I talk about these three elements in detail. In this video, we'll focus on how these three elements present in patients with schizophrenia. So the hallucinations that patients with schizophrenia develop are classically auditory. So they will say they can hear voices or they will notice strange sounds that aren't present. Delusions, as I talk about in the video on psychosis, are fixed false beliefs, and patients with schizophrenia can have all types of delusions. I talk about all the different types in the video on psychosis, but for example, they can have paranoid delusions where they think someone's coming after them. They can have grandiose delusions where they think they're king of the world, and many other types of delusions. The disorganized thought in patients with schizophrenia most often manifests as either tangential speech or circumstantial speech. Tangential speech means changing topics frequently and having difficulty answering questions. When you meet patients with schizophrenia on your psych rotations, you'll find that they're very difficult to talk to because it's hard to keep them focused and answer your questions without going on to other things. Circumstantial speech is very similar. Circumstantial speech refers to long, roundabout answers, and it takes them a long time to get around to answering your questions. So medical students are often asked to take a history of schizophrenics on their psych rotations, and this always proves to be a challenge because you find out that it's very hard to keep them on topic. In addition to psychosis, the second element of schizophrenia is cognitive impairment. Patients with schizophrenia have trouble processing information, they have difficulty paying attention, and in general, they have poor learning and memory compared with normal. And then the final element of schizophrenia are negative symptoms. So let's talk about what that means now. You can break the symptoms of schizophrenia up into so-called positive and negative symptoms. So positive symptoms are abnormal behaviors. They're behaviors that should not be there but are present. And these are most of the psychotic features of the disorder, things like hallucinations, delusions, and disorganized thought. The negative symptoms, on the other hand, are the absence of normal behaviors. So for example, many patients with schizophrenia have a flat affect. Their face lacks the normal expressions that a person has when they're talking or displaying emotion. Patients with schizophrenia often have a poverty of speech, meaning that they don't say much. This is called alogia. They have difficulty engaging in social interactions. This is called asociality. They also have avolition, which is a lack of motivation or a difficulty completing tasks. And then finally, they often have anhedonia, which is that they cannot feel pleasure. And these things are collectively called the negative symptoms of schizophrenia. And these are often the most difficult to treat. So despite therapy, even though you may be able to get patients' psychotic symptoms to go away, often these negative symptoms will persist to some degree. The lifetime prevalence of schizophrenia is about 1% globally. It has a slight male predominance, and it typically occurs in adolescence or young adulthood. In men, it occurs at about 18 to 25 years of age, like this guy on the screen here. And in women, it occurs at about 25 to 35 years of age. And this is very unfortunate because people with schizophrenia have often led normal lives up until the point when they develop this disorder. And then suddenly they develop features of psychosis and cognitive impairment and negative symptoms. And in many cases, this pulls them out of normal functioning in society. We don't know what causes schizophrenia, but there are some well-defined risk factors. So let's go through that now. First of all, schizophrenia is more common if you live in an urban area or a city compared to people who live in the country or less populated areas. Immigration is a risk factor for schizophrenia. There was a study in the United Kingdom that found that immigrants were 10 times more likely to develop schizophrenia compared to native-born citizens of the United Kingdom. Why this is the case, people do not know. There is a theory that schizophrenia is caused by something that happens at a specific moment when the person is developing in the womb. And the reason for this theory is because there are a number of obstetric complications associated with schizophrenia. In other words, if these complications happen to a mother when she's pregnant, her child is more likely to develop schizophrenia. These complications include hemorrhage, preterm labor, if there's a blood group mismatch between the mother and the fetus, fetal hypoxia, and maternal infection. Cannabis use or smoking pot is associated with schizophrenia, especially if people do this in adolescence. It's unclear whether this is cause and effect or not. It may be that people in adolescence have mild symptoms of schizophrenia and they smoke pot because it makes them feel better. On the other hand, it may be that there's something about smoking pot that leads to the disorder of schizophrenia. If you image the brain of patients with schizophrenia, or if someone with schizophrenia dies and you perform an autopsy, you will often find that the lateral ventricles of the brain are enlarged. The reason for this finding is not understood, but by way of review, these are the lateral ventricles shown in this picture on the screen here, and a classic finding in a patient with schizophrenia is enlargement of those ventricles. Another classic pathologic finding among patients with schizophrenia is abnormalities of the dendritic spines. If you look at this drawing of a neuron on the screen here, this is the dendrite at this end, and the dendrite has these little pokey projections that are called spines. They're small protrusions of neuron dendrites, and they receive input from other neurons at a synapse. These dendritic spines are lost in many brain regions among patients with schizophrenia. Once again, it's not understood how this leads to the disorder, but this is a classic pathology finding in patients who have schizophrenia. You should be aware that excess activity of the neurotransmitter dopamine is associated with schizophrenia. This is the structure of dopamine on the screen here, and there's something called the dopamine hypothesis, which states that too much dopamine activity is what leads to schizophrenia. And the reason for this hypothesis is because dopamine antagonists or blockers are often used for therapy, and they improve the symptoms of schizophrenia. And I talk about these drugs in the video on antipsychotics. You should know that schizophrenia has a high risk of suicide. 5% of schizophrenics commit suicide, and 10% of all suicides occur among schizophrenics. According to the DSM-5, the diagnosis of schizophrenia requires at least 1 month of 2 or more of the following features of schizophrenia: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and the negative symptoms we talked about earlier. In addition, the patient has to display continuous signs for at least 6 months. So, for example, if a patient has all of these symptoms for 6 months, then they have schizophrenia according to the DSM-5. On the other hand, a patient who has only 2 of these symptoms for 1 month does not have schizophrenia unless for another 5 months they display at least one of these features or some other feature of schizophrenia. So they would have 1 month with 2 features and then 5 months with other features. In contrast, schizophreniform disorder is a disorder that meets criteria for schizophrenia, but the duration is less than 6 months. Basically, you can think of this as a milder form of schizophrenia that does not last for at least 6 months. If you want to think of psychotic disorders along a spectrum, schizophrenia is one of the worst things you can have. Schizophreniform disorder is a milder version of schizophrenia. And then even milder than schizophreniform disorder is brief psychotic disorder. This occurs in patients who display psychotic symptoms with a sudden onset, but they fully remit within 1 month. This is more common in women. The classic presentation is a woman, and this commonly follows stressful life events. So, for example, a woman who suddenly loses her spouse can become so distressed that she essentially becomes briefly psychotic, but then it resolves within a few weeks. So classic stressful life events are death in the family, a loss of a job, something like this. Schizoaffective disorder means schizophrenia together with mania or depression. Some patients develop both schizophrenia and a mood disorder. And the most important thing to know about schizoaffective disorder is how to distinguish it from mania or depression with psychotic features. In the video on mood disorders, I talk about how some patients with mania or depression develop psychosis. So how do you know if a patient has mania or depression with psychosis or a schizoaffective disorder? Well, here's the trick. In order to have schizoaffective disorder, there must be some episodes of psychosis alone. In other words, some psychotic features that occur in absence of any evidence of mania or depression. The DSM-5 says that patients who have schizoaffective disorder must have 2 or more weeks with psychosis alone, and that is different from mania or depression with psychotic features. In that situation, all psychotic episodes occur in the setting of mania or depression. So here's a possible course of what someone with schizoaffective disorder might look like over a couple of months. The patient would have chronic psychotic symptoms related to schizophrenia, and then for a brief period of time, they would also have evidence of a mood disorder like mania or depression. Note that there are many periods in time, like here and here, where they are having psychotic symptoms alone. That is what you see in schizoaffective disorder. In contrast, for a patient with mood disorder with psychosis, they might have recurrent episodes of their mood disorder, and then during one particularly bad episode, they have some psychotic features. This is a mood disorder with psychosis. Note that the psychosis never occurs by itself outside of the mood symptoms. So now we've talked about schizophrenia, schizophreniform disorder, and brief psychotic disorder. Let's talk about one more disorder that has some features that resemble schizophrenia, and that is delusional disorder. Patients who have this condition have one or more delusions that last for a month or longer, but other than the delusion, they have no abnormal behavior. So, for example, a person with delusional disorder might believe he is being followed for 2 months and he frequently checks for someone behind him. You can't persuade him that he is safe. That's a feature of a delusion, is that you can't talk patients out of this. But importantly, he has nothing else to suggest schizophrenia. No hallucinations, no disorganized thought, no negative symptoms. This person has isolated delusions, and that is delusional disorder. When you're faced with board questions about psychiatric psychotic syndromes, you want to start to tick off what the patient has. Do they have delusions? Do they have hallucinations? Do they have disorganized thought? Depending on the number of those you see, it will tell you what the correct answer is. If you only see a description of delusions, then they may be describing delusional disorder. And in rare cases, something can occur in delusional disorder called philia do, which means the madness of two. This is when a close friend of the person with delusional disorder starts to agree with the person with delusional disorder and shares the delusion. In other words, the person with delusional disorder is so convincing that he or she gets a friend to believe the same delusion. I'll finish this module by talking about one additional psychotic disorder, and that is postpartum psychosis. This is a very rare disorder that complicates a very small number of births. It almost always occurs in a woman who gives birth who had a known psychiatric disorder prior to becoming pregnant. Most commonly, it's bipolar disorder, although sometimes you also see it in women who have depression with psychosis or schizophrenia or schizoaffective disorder. And it classically occurs in a woman who stopped her meds during pregnancy because she didn't want to harm the baby. This will present usually within 2 weeks following delivery of the baby. Women with postpartum psychosis can have all the usual features of psychosis, things like delusions, hallucinations, and disorganized thought. The delusions often involve the baby, like something being wrong with the baby or someone trying to hurt the baby. And classically, the delusions are related or similar to the patient's mood. So, for example, if the mother is in a depressed state, then she will have negative delusions about the baby, like something is wrong with my baby. Risk factors include a personal or family history of the disorder. As I mentioned earlier, this classically occurs in women who have a known psychiatric condition at the time they become pregnant. This is often bipolar disorder, but can also be things like schizophrenia and schizoaffective disorder. The first pregnancy is a risk factor, and the idea here is that once a woman has had one pregnancy and has not developed postpartum psychosis, then she has declared herself as a person unlikely to get psychosis after delivering her baby. A woman who is pregnant for the first time, you don't know what's going to happen to her, and therefore that's the group where you're more likely to find this condition occurring. And then also, as I mentioned earlier, this occurs among women who discontinue their psychiatric medications in pregnancy. What you need to know about this and what they're going to ask you on your boards is that women who have this must be hospitalized. There's a very high risk of suicide. There is a small but not zero risk of harm to the baby, and the mother is not in a condition to care for herself or the baby. So they will ask you what the best next step is, and the answer is hospitalization. The treatment is medication. There are some antipsychotic drugs that can be used in postpartum psychosis, and also in some cases electroconvulsive therapy. Electroshock therapy does not involve drugs, and therefore it's often a good idea in a woman who has just delivered a baby and may need to breastfeed. And that concludes our video on schizophrenia.